Hello, this is Dr. Lori Brado from the Multidisciplinary Vulvodynia program, and I'm here today with Dr. Sydney Thomson, who's a gynecologist in our program. Hi, Sydney.
Hello.
Can you tell us just a little bit about the kinds of patients that you see?
Sure. Obviously, within the program, we are exclusively seeing patients with vulvodynia, or painful intercourse. My practice includes primarily sexual concerns for women, which includes pain conditions, sexual desire concerns, arousal concerns, orgasmic concerns. So basically, my focus is female sexuality.
Great. And so we're here to talk a little bit about the various treatments for the condition, vulvodynia, and I'm hoping that we can focus on medications for this condition. Why would one prescribe medications for a genital pain problem?
Right. That's an excellent question, and I guess part of being within the program that we spend a fair amount of time trying to answer that specific question. In the context of the time we have now, basically understanding that vulvodynia is a nerve pain condition. So we're talking about something that has initially inflamed or irritated the tissues at the vaginal entry. But eventually there's a sensitization that happens first locally that leads to touch being painful. And that sensitization happens not only locally, but eventually through the whole neurologic system, so right through the spinal cord and up into our brain. So as far as delivering pain control, medications can be a very helpful tool to address the pain in this condition.
Great. And so sometimes women have questions about just the variety of medications that are available. Can you talk a little bit about what are the kinds of medications that are used and how effective are they?
Sure. Now these medications we're going to talk about aren't used exclusively for this condition of vulvodynia. They've been used for years and years in other neurologic pain conditions. They've also been tested in regards to pain control in vulvodynia and found to be effective. So we basically pool a lot of the information we get both in the study for vulvodynia but also other neurologic pain conditions. So the three families primarily used are firstly tricyclic antidepressant medications. The second family is a crossover of an antidepressant family that involves serotonin activity, but also something called noradrenaline and dopamine activity. But it essentially is an antidepressant as well. And the third family is anti-seizure medications that basically we use pretty much exclusively now for the treatment.
Great. And so you said that two of those three classes are antidepressant-like drugs. Does this mean that if a woman with genital pain receives one of these conditions that she's depressed necessarily?
Again, a good question. I think what most women that we begin talking to around their treatment plan ask. Yes, in fact, these medications, one of their indications for use in these two particular families are depression and anxiety conditions. But we've also found, separate from that indication, they can be used exclusively for pain management, and we are talking about neuralgic pain conditions. So it's basically not going to affect, in a sense, the mood of that individual, personality of that individual, if in fact there is not a depression or anxiety condition present.
Great. Okay. And can you say a little bit about what are some of the common types of those different 3 classes of medications that a woman with genital pain might be prescribed?
Sure. So within the tricyclics, there's a number of different names. Amitriptyline used to be trade name of Elavil, nortriptyline, dazipamine. Those are the common, commonly prescribed medications within the first family. The second family of, again, the antidepressant is venlafaxine, which the trade name is Effexor. And the third family, the anti-seizure medicines, again, the common medications prescribed from that family are gabapentin, which is the trade name of Neurontin, pregabalin, which is trade name Lyrica, and there's a number of other anti-seizure medications as well that sometimes are used, but those 2 primarily.
Great. Do these medications alone work? So if a woman with genital pain comes to see you, could she have an improvement in her genital pain by simply using one of these medications?
Well, it's an important concept that needs to be understood. Medications for pain control, pain management, pain treatment in this condition are very useful tools. The problem with neuralgic pain is, as we touched on initially, this whole process of sensitization that happens both locally in the tissues of the vaginal entry and through the neurologic system, spinal cord and the brain. And so in that, you need to understand that our internal environment very much influences the ability for these medications to work. There are very common factors that we see that contribute to detriment as far as getting pain control. In fact, in these situations, they can actually excite the whole situation, and what that means is more pain. And so that means, when we look at what are those factors, things that are well proven, researched, depression or anxiety conditions, stress, fatigue, they are common situations in which we see the whole neurologic system fired up from a pain perspective. So unless we address those elements, it's very hard to get pain control no matter what you're using. The other aspect of it is pain is a very powerful emotion, if I can put it in that term, and it very much affects how we think. And the process of our thinking, our thought patterns very much also become impacted from even from first experiencing the pain or even anticipating the pain. And so the thoughts of around the pain, why is this happening, frustration, will I be able to have a baby, will my partner leave me, the behaviors, the emotions that can go with that, sadness, frustration, anger, and ultimately behaviors, again, are a very important component of pain management. So if all of that is potential for exaggeration or catastrophization of all of that process is not, again, addressed, again, medications have a very hard time working on their own. So it's a bigger picture than just the meds, but they can be a very important component of that.
Great. And so if a woman is on the medications and has an improvement in her pain, and then she and her doctor eventually decide to stop the medications, should she be worried about the pain coming back?
Well, basically, the approach used at the MVP program is the idea to maintain a pain-free situation, which for most of the women that we're dealing with means intercourse without pain. What you want to do is maintain that situation for at least 6 months with, all of the other pieces that we talked about. And then at that point, it's reasonable to trial a person off of the medication, so meaning slowly off over a week or two. If there's breakthrough of the pain, then there needs to be negotiation with the caregiver and the patient around starting back on the medication, staying on for another 3 months, 6 months. If there's complete resolution of the pain, great. Then obviously the medications do not need to be restarted. There is a small group of women who, each time we try to bring them off of the medications, they get a breakthrough of the burning pain. And so with that individual, we have to look at, generally where they are in the sense of their life events, and decide basically whether they're going to be maintained on the medications or have drug-free intervals, i.e. for things like pregnancy and other personal choice.
Great. This has been very useful information for women with provoked vestibulodynia. Is there anything else that you want to add with regards to the role of medications in this condition?
Not so much the medications, although I think it can be a bit daunting for women to even have these initial conversations around these families of medications, antidepressant medications, anti-seizure medications. It can feel just a little bit over the top in the sense of these are often women that are dealing with being comfortable unless the area is touched. So it's hard to take on the idea of needing a medication that may have some side effects. Just the whole idea of taking medications for something that doesn't affect them all through the day. Ultimately, though, once you begin to understand what is actually going on in the process of this condition, it becomes more understandable why these medications are necessary. And finally, I guess just to say that it alone, in the context of what we've talked about, the sort of general physical, emotional health, thinking process, is not enough. You need to combine it with the pelvic floor, physiotherapy and biofeedback, and basically looking at the sexual health piece, helping a woman restore her confidence in her sexual health, as well as a couple restoring their ability to be together sexually and being confident and comfortable with physical intimacy. So the approach is multi-pronged, and that's why we're a multidisciplinary program. And so each piece has its own very important piece to play, important part of the puzzle to fill.
Great. Thank you again, Dr. Thomson. This has been very useful information.
You're welcome.